Method 3-15, Antibody Titration Procedure. Titration is a semi-quantitative method used to determine the concentration of an antibody in a serum sample or to compare the strength of antigen expression on different red cell samples. The usual application of titration studies are as follows. Number 1, estimating antibody activity in alloimmunized pregnant women to determine whether and when to perform more complex investigation of the fetal condition. Number 2, elucidating autoantibody specificity. Number 3, characterizing antibodies as having high titer and low avidity traits. These traits are common in antibodies to antigens of the Knops and Cheeto-Rogers system, COST-A and JMH, or John Mueller-Henton. And finally, number 4, observing the effect of sulfhydryl reagents on antibody behavior to determine immunoglobulin class, IgG or IgM. Your specimen will be serum or plasma with an antibody to be titered, and you'll need reagent red cells that express the antigen corresponding to the antibody specificity. I'll let you read the procedure actions in the method 3-15. They're essentially left up to interpretation about how you'd like to create a master dilution. I'm going to show you a video of how I perform a titer and how I performed it at the facilities that I've worked in, but they can vary depending on where you work. So I'll take as seen on the left side of the screen, a certain amount of neat plasma, about 1 to 2 mils. And then I'll create a saline tube, and I'll also create the reciprocal of serum dilutions. So I'll start with 1, then next 2, 4, 8, 16, 32, 64, 128, 256, and so on down the line. If I'm unclear about what the titer number will be, I'll do up to 512. So I'll add saline to this tube that I've listed as saline. Then I'll take 100 microliters in a calibrated pipette, and I'll add saline 100 microliters to tubes 2 through 512. As you may have noticed, I did not add saline to tube number 1. I check to ensure that there is a visible liquid at the bottom of tubes 2 through 512. Again, as shown in this image, tube number 1 is a 1-to-1 dilution, therefore there is no saline remaining in that tube. I check all my tubes to make sure that I can see a clear liquid and that they correspond to what I expect in the tubes. Now that I've added saline to tubes 2 through 512, I'm going to add my patient plasma to begin my titration of serial dilutions. I'll need more than one pipette tip. We use separate pipette tips for each dilution to reduce carryover between mixing. I'll take a brand new pipette tip and I'll add 100 microliters of patient plasma to tube number 1. Recall that tube number 1 has no saline in the tube. To tube number 2, I'll add 100 microliters of patient plasma. This tube contains 100 microliters of saline and 100 microliters of patient plasma. This is a 1-to-2 dilution. Next, I'll take a new pipette tip, a very important step, and I'll mix the sample several times. I'll then add the 1:2 dilution to tube number 4. As soon as I add, I discard the pipette tip. Tube number 4 now contains 100 microliters of saline and 100 microliters of dilution number 2. As soon as I add the plasma, I'll remove the pipette tip and I'll apply a new pipette tip. Once I'm done with the addition in the tube with plasma, I'll move the completed tube back in the rack to indicate plasma is added. Just a reminder for myself. I'll mix the content of tube number 4 using a brand new pipette tip, so I can get a homogeneous mixture. I'll then add this mixture to tube number 8. Again, tube number 8 has plasma of dilution 4 and 100 microliters of saline. I'll fast forward through the remaining tubes. Note how as the dilution becomes greater, the color of the plasma becomes lighter, so it's more difficult to identify if plasma is added. Here are all my pipette tips, which I discard. Next, I take 1 drop of reagent red blood cells here. 1 drop equals approximately 100 microliters, so I'll add a single drop to all of the remaining tubes, and this is my titration. I'll mix the tubes, and they are now ready for incubation. The incubation occurs typically at 37 degrees. The final stages of your titer, to avoid misinterpretation of results, it may be preferable to examine the first tube containing the most dilute serum, meaning you'll read tube 512 first and then work your way down to 1. This is again to avoid misinterpretation of results. When you observe the highest dilution that produces a 1+ macroscopic agglutination, this is your titer level that is reported. The titer endpoint is the reciprocal of the dilution, so a 1:32 dilution is a titer endpoint of 32. In comparative studies, a significant difference in titer is 3 or more dilutions. Titers are quite subjective, and variations in technique and inherent biologic variability can cause duplicate tests to give results that differ by 1 dilution in either direction. Titer values alone can sometimes be misleading to physicians, so we can include a representative score. It's a semi-quantitative measurement of antibody reactivity. Again, the score is not commonly used any longer. I believe it was more popular before our time. The scoring method is a little difficult to learn, and I wouldn't spend a lot of time learning about it. The arbitrary assigned threshold for significance in comparing scores is a difference of 10 or more between different samples. Antibodies with high titer and low avidity characteristics generally have a titer greater than 64. The table below shows the results obtained with 3 different sera, each of which shows no more agglutination after 256. The differences in score, however, indicate considerable variation in strength of reactivity. So this example really demonstrates how all of these titers have the same endpoint, but very different scores. So there is value to a score if it's requested. The notes section is fairly straightforward. As I stated before, pipettes with disposable tips should be changed after each dilution, or it's recommended, as to not have carryover from each tube. It's a very sensitive test. Also, when the titers of several antibody-containing sera are to be compared, all of them should be tested against red cells from the same donor, preferably. If this is not possible, the test should use a pool of reagent red cells from donors of the same phenotype. Comparisons are valid only when specimens are tested concurrently. There is a separate method for performing a titration for an anti-D for hemolytic disease of the fetus and newborn. If you'd like to read that, you can refer to method 5-3.